Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining our program today, Public Health Threats, Superbugs. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts and sign-in sheets as well as the evaluations are available online, and you will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may be relevant, CE credit will only be awarded for 1 year for nurses expiring on December 31st, 2019, and 2 years for social workers expiring on December 31st, 2020. I'm Karen Landers, District Medical Officer here at the Alabama Department of Public Health. A little later in the program, I will be discussing multi-drug resistant and extensively drug-resistant TB. But first, we will learn more about antimicrobial-resistant gonorrhea from Dr. Edward Hook, an infectious disease specialist at the University of Alabama in Birmingham. Welcome, Dr. Hook.
Thank you, Dr. Landers. It's a pleasure to be here, and it's a pleasure to be talking to you today about this important public health topic. Before I start my talk, I need to acknowledge for everybody out there that I have received research support from a number of different companies, as well as the NIH, the CDC, and the World Health Organization. I don't think that any of those relationships are going to change what I'm going to say to you, but it's important for you to have that knowledge. So as we talk today about gonorrhea, while the focus will be on emerging antibiotic resistance and the problems that we have in choosing the best therapy for the disease, we have to put that in context. So we're going to start our conversation today with a little bit of a review of the epidemiology of gonorrhea, some of the facts about gonorrhea diagnosis, and how that affects our ability to diagnose antibiotic-resistant gonorrhea. And then our major focus is going to be treatment, the emergence of antibiotic resistance, and the other control measures that we use for treating this very common public health problem. It's important to acknowledge that gonorrhea, while it's a large problem here in Alabama and in the United States, it's a global problem. Last year, there were nearly 60 million new cases of gonorrhea occurring worldwide. So the problem that we have as our world shrinks more and more is not something that's local, but is global. Here in the United States, many of you may have seen this slide from the Centers for Disease Control and Prevention. They indicate that our gonorrhea rates in our country have increased by 67% over the past 5 years. That rate of increase begins to approach the rates of increase that we saw last in the 1970s. So the problem of both increasing gonorrhea rates as well as challenges to treatment is not a new problem, but a re-emerging problem. This slide from the CDC looks at our national gonorrhea rates as reported to the CDC over the past 40 or 50 years. As you can see, in the 1970s, gonorrhea rates in our country went up very rapidly and for a sustained period of time. There were a number of things that contributed to that, and then gradually over the 1980s, 90s, and into the beginning of the 21st century, the disease declined and leveled out. But it never really went away, and as I've just mentioned, more recently, the disease has begun to increase more and more. So let's look a little bit more at local trends and national trends more recently in gonorrhea epidemiology. Let's start by talking about the gender of persons who are acquiring gonorrhea. Gonorrhea obviously occurs and affects both men and women, and its complications are most severe for women, causing infertility and ectopic pregnancy. In recent years, however, gonorrhea rates have gone up more amongst men than in women. That's not to say that it's not an important problem in terms of infections in women, but both genders are widely affected. It's also important to remember that much gonorrhea in women is asymptomatic, so testing and screening is an important first step in diagnosing this. On the other hand, about 90% of men with gonorrhea develop symptoms of their infection, and then, but 10% are asymptomatic. Those symptoms are not so severe, and in fact, recent research that we've carried out at UAB show that of men who have gonorrhea and come to public health clinics, almost 1 of 4 of them have had sex since the onset of their symptoms. So the continued spread of gonorrhea remains an important public health problem. As shown in this slide, which looks at gonorrhea rates by age, we can see that gonorrhea is a disease of youth. That is, adolescents and young adults have the highest gonorrhea rates, and while individuals can have gonorrhea throughout the lifespan, the highest rates, and therefore the group that we need to educate about the disease, the group that we need to preferentially test about the disease, tend to be sexually active teenagers and young adults. The geography of gonorrhea is also important to us here in Alabama and in the southeastern United States. Gonorrhea rates are not homogeneous throughout the United States, but in fact, as has long been the case, gonorrhea rates, as well as other sexually transmitted infections, are more common here in the southeastern United States than they are in some of the other parts of the nation. So gonorrhea is a familiar problem to those of us involved in public health for our patients, taking care of patients in gonorrhea. This slide just amplifies that statement, showing the gonorrhea rates by region, breaking things up into the South, which, as you can see, has always been at the top level, the East, the Northeast, the Midwest, and the West. The rates are certainly increasing faster in the West today than they were in the past, but they have not caught our rates here in the southeastern United States. So this is a problem for all of us who care for patients regularly in Alabama and in the southeastern United States. The other thing that I have to acknowledge is that, sadly, gonorrhea is another example of health disparities, and rates of gonorrhea in Black Americans are substantially higher than they are in other race and ethnic groups. This is an important thing to acknowledge. If we don't acknowledge it, we can't address it. So, in terms of the epidemiology of this disease in the United States, some of the things I've already mentioned are on this slide, and there may be a few others. The things that are associated with increased rates of gonorrhea: first of all, health disparities. Gonorrhea tends to be 10 times greater in blacks than in whites. Pardon me. It's also more common in individuals living in America's cities, people who have lower socioeconomic status, people who have their onset of sexual activity at an earlier age. I think it's logical that single people have higher rates of gonorrhea than people who are in married relationships. People who've had gonorrhea once are more likely to get it again than somebody who's never had the problem. And then finally, as we'll be emphasizing today, the problems of antibiotic resistance and gonorrhea at non-genital sites, that is, the throat and the rectum, are becoming an increasing focus of our efforts to control this all too common disease. Lastly, I think it's important to acknowledge that when we're dealing with sexually transmitted diseases, all too often people don't have one STD, but more than one, and that they affect each other. This is a study looking at HIV in persons and men who have urethritis. Most of this urethritis, these urethral infections, were men with gonorrhea. Amongst persons with HIV, at the time they presented with their gonorrhea, they had just as much HIV in their genital secretions as they had circulating in their blood. After treatment, the amount of gonorrhea present in genital secretions declined substantially. Thus, this shows us that gonorrhea tends to amplify the presence of HIV and make it more easily transmittable to other people. So that when we evaluate our patients with and at risk for sexually transmitted infections, it's important to consider the broad range of sexually transmitted infections which might occur. To elaborate on this point, that gonorrhea is associated with increased rates of HIV and therefore HIV transmission in persons who have both diseases, let me also demonstrate that, as we've already talked about, the amount of HIV in genital secretions decreases following treatment. But while gonorrhea becomes non-infectious within a few hours or certainly within a day of treatment, the amounts of elevated HIV remain present for several weeks before they get down to the normal levels. So once again, I think it's far better to prevent gonorrhea than it is to have to treat it. When we treat it, we want to treat it as quickly as possible, and we want to encourage our patients to abstain from sex while they get better from their treatment. With that review of gonococcal epidemiology, let's just say a few words about the diagnosis of this infection as well. There are several different ways to approach the diagnosis of gonorrhea. The Gram stain, which can be done in just a few minutes with inexpensive reagents, is a very helpful tool in settings where we do have microscopes and microscopic examination available. In the past, we used to rely on culture to detect gonorrhea, and culture remains very important because it's only with culture that we can test the organisms for antibiotic resistance. Thus, culture remains an important part of our efforts to understand this wily organism and to monitor its susceptibility to the antibiotics we use. Most importantly, however, here in Alabama and across the United States, we've now adopted nucleic acid amplification tests, the tests that are listed at the bottom. Here in Alabama, our state laboratory provides nucleic acid amplification tests by Hologic for our testing of gonorrhea, and those are great tests for diagnosing this very common infection. By way of historical information, this is a picture of a culture for gonorrhea, but as I said, we no longer use this as our preferred method for diagnosis, and only do this in a limited number of sites where we are able to test for antibiotic resistance. The nucleic acid amplification tests that have taken the place of culture have made a change in the way we diagnose gonorrhea. It used to be that we worried a lot about the quality of the specimen that we collected from our patients with gonorrhea. We needed to do a speculum examination on women. We needed to do a urethral swab in men. On the other hand, with these new tests, specimen collection has become much more easy. Men and women can both be tested with a voided urine specimen and have accurate diagnoses of gonorrhea. In fact, as you'll see in just a moment, diagnoses of gonorrhea that are more accurate than cultures used to be. In addition, women can be tested by a vaginal swab taken without a speculum or an endocervical swab taken during a speculum examination. So these new tests have not only become more sensitive, but they're easier specimens to collect. Here in Alabama, we adopted the use of nucleic acid amplification tests for diagnosing both gonorrhea and chlamydia in about 2005. And the effect was dramatic. As you can see on this slide, in the year before October 1, 2005, here in Alabama, we had about 6,700 cases of gonorrhea. That number of cases detected went up by 6% over the next year after adoption of these nucleic acid amplification tests. Thus, these are more sensitive tests for diagnosing gonorrhea. It's also worth noting that these same tests, where we can test both for gonorrhea and chlamydia at the same time in the same specimen, are a third more sensitive for diagnosis of chlamydia as well. So our life has become easier and our diagnostic testing has become more accurate since the Alabama Department of Health has provided us with opportunities to do this nucleic acid amplification testing for our patients tested for gonorrhea. The other thing that these tests have done has been to make it easier to diagnose gonorrhea in sites that we normally didn't look for gonorrhea. This is another UAB study that was done in which patients who performed oral sex on partners, both men and women, were tested both at genital sites and in the throat for gonorrhea. What I want to show you is that using nucleic acid amplification tests, we detected gonorrhea only at the throat in 1/3 of patients with gonorrhea. It turns out that pharyngeal gonorrhea is much more common than we used to think, and that for patients who are performing oral sex on sexual partners in the context of sexual activity, the throat may be a site of infection. That has important ramifications, as we'll talk about in just a few moments, in how we treat our patients with gonorrhea. So with that, let's talk about gonorrhea treatment. Pardon me, I have a cold. When we talk about the treatment of gonorrhea, we need to have a little bit of a history lecture. So let's go back and let's think about the 1940s before we had modern antibiotics. And we used to treat people, or at least people used to take medicines like Dr. Reed's Eureka Tonic. And for those of you who can't read the fine print here, you'll see that this tonic was said to give people vim, vigor, and provide excitement and to weak and run-down folks. And it, as well as curing their syphilis, whatever that was. As a matter of fact, however, it probably did make people feel better. It was a solution which contained both alcohol and cocaine. I'm not sure it helped their gonorrhea, but I suspect it did make people feel better. After patent medicines like this, scientists began to treat gonorrhea in different ways through what they called irrigation therapy, in which, in this picture from an old textbook, perhaps you can see that there was a funnel that was put and adjusted, and through gravity was used to infuse things like potassium hydroxide, potassium permanganate, other caustic substances into the urethra in the efforts to cure gonorrhea. There were equally vile-looking instruments available to treat gonorrhea in women as well. Well, I'm not sure how well these treatments worked. I'm sure that they were a disincentive to getting infected again. After antiseptic solutions were used for gonorrhea, we had the beginning of the antibiotic era. And the first antibiotics we ever had were sulfa drugs with sulfanilamide. The great thing about sulfa drugs is that they could be taken by mouth and they reliably cured gonorrhea. But they only did that for about 6 years. And in the interval between 1937, when sulfa drugs became available, and 1944, cure rates went down from 100% to about 65% in patients treated with maximal doses of sulfa drugs. Fortunately, in 1943, penicillin became available and became the drug of choice for treating gonorrhea. It remained the drug of choice for the next 30 or more years, although the amount of penicillin required to cure gonorrhea increased by 100-fold. So even with our first antibiotics, what we've learned is that this bacteria is able to develop resistance to the treatments we use to treat our patients with the disease. Since that time, the gonococcal bacteria has developed resistance to virtually every antibiotic we've used for treatment. Sulfa drugs, penicillins, macrolides like erythromycin and azithromycin, tetracyclines, aminoglycosides, spectinomycin, and fluoroquinolones like ciprofloxacin and ofloxacin. The way that the organism does this is varied. The gonococcus can develop resistance through a variety of different mechanisms. It can be resistant because its cell wall doesn't let antibiotics into the bacteria. It can be resistant because it has enzymes that inactivate antibiotics. It can be resistant because of the internal workings and the way the bacteria divides. But the sum total is that we now know that there are over 50 different mutations which code for antibiotic resistance in gonorrhea. As I've already alluded to, this is not a new problem. This problem probably started the first day that the first patient was treated with sulfa drugs. Our problem today, however, is compounded not only by the fact that the bacteria continues to develop resistance, but that the number of new drugs that we have for treating gonorrhea has decreased. And so with fewer new drugs, we are having more and more trouble determining and finding effective therapy for gonorrhea. Continuing our history lesson, I'll mention that for over 40 years, the CDC has had the gonococcal isolate surveillance project, which follows antibiotic resistance here in the United States. I mention this because in the next few slides I'll be showing slides of gonococcal antibiotic resistance developing over time in the United States. Here in Alabama, we collect specimens on a monthly basis in Birmingham, Alabama, to contribute to the gonococcal isolate surveillance project. So indeed, we here in Alabama can use the same data that I'm about to report. In 2016, isolates from the gonococcal isolate surveillance project showed that there were many different forms of antibiotic resistance in gonorrhea. That over half of gonorrhea bacteria were still sensitive to virtually all antibiotics we used, but that there were other forms of resistance which affected nearly 45% of all gonorrhea. And that is part of the challenge we're dealing with today. In the 1990s, drugs like ciprofloxacin and ofloxacin, which we used widely here in Alabama, became the preferred drugs for treating gonorrhea. What the gonococcal isolate surveillance project showed was that while we were using the drugs, the organism was becoming less and less susceptible to those antibiotics. This slide shows the steady increase in antibiotic resistance to ciprofloxacin amongst gonorrhea across the United States over time. Of course, those sorts of changes warranted changes in our treatment recommendations. Before I do that, I'll also mention that this data showed that fluoroquinolone-resistant gonorrhea increased in different parts of the countries at different rates. It's not apparent from this slide. You'll have to trust me to say that that the graph that goes up first is occurring in the West Coast, and it's occurring disproportionately among men who have sex with men. And that later, here in the East and the Southeastern United States, and amongst heterosexual men and women, the rates began to increase as well. Nobody escapes the development of antibiotic resistance. In 2006, as the bacteria was becoming more and more resistant to ciprofloxacin and ofloxacin and related drugs, the CDC finally said we had to change our treatment. And these drugs, which had been easy to administer and well tolerated by our patients, could no longer be recommended for gonorrhea treatment. At that point, beginning in 2006 and becoming official in the 2010 CDC STD treatment guidelines, we were left with only one class of antibiotics to treat gonorrhea: cephalosporin antibiotics. These drugs are familiar to many of you in the audience. Ceftriaxone was made the drug of choice, or alternatively, we were able to use an oral therapy which did not require injection, cefixime. It was also recommended that people receive azithromycin at the same time that they received ceftriaxone or cefixime. Alternatives to azithromycin were doxycycline. The addition of azithromycin or doxycycline were provided in order to treat coexistent chlamydial infection. History repeats itself, however, and that's part of our message. Indeed, in this, and sadly, this is probably a hard-to-read slide, and I apologize to those of you out there, but what this slide shows is that between 1999 and 2016, as we relied more and more on cephalosporins for treating gonorrhea, indeed, we began to see more and more resistance. And that resistance first arising in the Far East in Japan and Hong Kong, and then moving to Europe and Australia, and finally to the United States, continued to spread. In 2013, in Toronto, Canada, to the north of us, there was an outbreak of gonorrhea, which is worth pointing out to you because this was the first sustained outbreak of gonorrhea which had resistance to cefixime. And based on this recommendation, cefixime was then edited out of our STD treatment guidelines. Looking at this outbreak, it also showed several points that are relevant to us today. First of all, it showed that the information collected through the gonococcal isolate surveillance project was relevant to how patients with gonorrhea were treated. The more resistant an organism was, the more likely it was to fail therapy. The second point, listed at the bottom of this slide, is that different sites of infection were more likely to fail therapy with cefixime. In the Toronto outbreak, about 5% of isolates occurring at urethral infections in men failed therapy. For rectal infections, that rate went up to almost 8%. And in the small number of throat and pharyngeal infections that were discovered, the treatment failure rate was nearly 30%. We've known for a long time that treating gonorrhea at the throat was more of a problem and more challenging than treating gonorrhea at other sites. That continues to be a challenge for us today. So where did that take us? In 2015, at the STD treatment guidelines, our treatment options were reduced to a single drug, ceftriaxone, given in a dose, an injection of 250 milligrams. At this time, doxycycline was taken off the list of drugs to be given with the ceftriaxone because the gonococcus had become increasingly resistant to those drugs. In addition, it was felt that the addition of azithromycin to ceftriaxone might have an additive effect in killing the gonococcal bacteria, so that whether or not the patient had chlamydia, it was important to treat patients with both ceftriaxone and azithromycin. That is the currently recommended treatment for treatment of gonorrhea here in the United States. We will be reviewing those guidelines in June of next year to look at an update in gonococcal treatment. Because there aren't a lot of new drugs, there will probably not be a major change. What were the alternatives to ceftriaxone plus azithromycin? Well, grudgingly, the CDC suggested that we could still use cefixime if we used azithromycin at the same time, but they emphasized that at that point it was important to return to a practice that we hadn't participated in nearly 30 years. That is, doing a test of cure, asking patients to come back for repeat testing to make sure that they were cured. In addition, in the past, it had been suggested that a single 2-gram dose of azithromycin might be effective if patients said that they were allergic to cephalosporin antibiotics. But it was felt that this was no longer reliable, and there were concerns about increasing treatment failures related to this. So what was left? What was next? Where are we now? In the CDC treatment guidelines, there is what's called salvage therapy, and I think that name, salvage therapy, is the correct way to talk about this, because these are not easy therapies to give. The two regimens for salvage therapy are either an injection of gentamicin, 240 milligrams, plus 2 grams of azithromycin given by mouth. This is tough treatment. You have to give a shot to the patients, and the azithromycin causes GI toxicity in that regimen. An alternative salvage therapy was to give 340 milligrams of gemifloxacin, an antibiotic, which I might add, that's very hard to get, and azithromycin, 2 grams. And in fact, with that particular regimen, almost 1 in 4 patients who took the medicine had severe GI toxicity, and many of those patients even vomited. The stimulus and the challenge of increasing resistance in gonorrhea, however, has led to a few clinical trials. You see red lines through 2 of the drugs that were evaluated for gonorrhea therapy, solithromycin and delafloxacin, whose cure rates were insufficient to reliably cure gonorrhea. More recently, 2 new drugs, they first had numbers and names, and now they have true names, zoliflodacin and geptodidacin, were studied in phase 2 trials, which and showed that those drugs have promise for gonorrhea treatment. This slide shows the data that were published just last month in the New England Journal of Medicine, in which we at UAB were privileged to take part in, looking at zoliflodacin for treatment of gonorrhea. It was compared to a large dose of ceftriaxone, 500 milligrams. The zoliflodacin was given orally, either 2 grams or 3 grams. And as you can see on this slide, the cure rates were close to 100% for both doses of this antibiotic. The problem in this study is that when we had pharyngeal gonorrhea, and again, the numbers of pharyngeal gonorrhea were modest, unfortunately, the failure rates were once again higher. I think this was probably to be expected. Nonetheless, based on this phase 2 clinical trial, there has been a decision to pursue this drug in treatment. I'll be helping to head this study. It'll be led by a group called the Global Antibiotic Research and Development Partnership, which is a partnership between the company that makes this drug, the National Institutes of Health, and the World Health Organization. It's a study that will be done in several different sites, including the United States, Thailand, South Africa, and the Netherlands. It's a non-cephalosporin antibiotic, so if effective, and if proven to be effective, it would be effective for persons who are allergic to cephalosporin, as well as having the advantage of being an oral antibiotic rather than an injection. Unfortunately, this clinical trial will not go into the field until this summer. So this is on the horizon, and it gives us hope that there are more drugs coming forward. But for now, we're stuck. Ceftriaxone plus azithromycin or salvage therapy. On this slide, this is my guess, and I think it's probably a good guess, but it's admittedly still a guess, as to what's coming. I think it's a sure thing that antibiotic resistance will continue to progress. It started when we started with antibiotics. There's no doubt in my mind that it will continue to progress. I fear that as clinicians we'll be asked once again to return to asking our patients to return for test of cure. There's a pressing need to understand whether pharyngeal gonorrhea, and rectal gonorrhea as well, is important in terms of creating morbidity for people with those infections, or whether it's sufficient to focus our treatment efforts in people with genital infections. There will be new antibiotics coming, but as I've already said, a clinical trial will take at least 3 years to occur. Dual therapy, that is, 2 antibiotics given at once, will continue to be promoted in the hopes that they will slow the development of resistance. We also may go back to the days where we have to give antibiotics more than a single time to treat gonorrhea. This is a rather dour picture, but I have to also say the good news is that our currently recommended therapy is well tolerated by most patients and has a more than 95% cure rate. So while the fear and concerns about developing antibiotic resistance is there for us, the good news is that the therapy that we have right now still works. I'm going to skip over this slide regarding research questions. I think that sort of summarize the sorts of things that investigators are interested in. Where does resistance come from? How to best slow the development of resistance? How important is gonorrhea at the throat? But we won't go into those things at this time. I think they're probably not important to most of us in the day-to-day treatment of our patients. I do want to finish up, however, with a few comments regarding control measures, because I think that while we think about treatment of gonorrhea and we're faced with occasional treatment failures, it's important to realize that while antibiotic resistance is one reason for treatment, there are other reasons. First and foremost is the problem of reinfection. Partner notification, that is, the notification of sexual partners, irrespective of the presence or absence of symptoms, who have been recently exposed to a partner with gonorrhea, is an important element for our public health efforts to control this disease. People who do not know that they're infected can transmit the infection to others. Secondly, all too many patients use the wrong therapy, and sometimes clinicians use the wrong therapy for treating their infections, either because they've made the wrong diagnosis, or they've used the wrong dose of medications, or the patients have tried to medicate themselves. It's important to remember our recommended treatment guidelines: 250 milligrams of ceftriaxone plus azithromycin, and then resistant organisms, of course. Finally, I just want to remind everybody that when we think about gonorrhea in our nation, that gonorrhea rates in our nation are affected by three different things. The infectivity of the bacteria, that's a biological characteristic of gonorrhea. We can reduce infectivity by using condoms. Next month, I'll be going to the World Health Organization for a conference on gonococcal vaccines, which is something that we hope will be in the future, but don't exist right now. Second, sexual partner selection. That is, being cautious, making appropriate choices, monogamous wherever possible, and partner notification of exposed partners is another important element of gonorrhea control. And then finally, efforts to stop infectivity by gonorrhea through expeditious and use of effective therapy is the cornerstone to controlling this all too common disease. So, this is just saying the same things in a slightly more direct way. Expeditious diagnosis and therapy is critical to our efforts to control this infection. Encouraging our patients, always our patients, even our patients who've had the disease before, to curtail their number of sexual partners and to use condoms is appropriate. And in the future, we hope that they'll have a vaccine. But for now, the things on the top of the slide are the things that as clinicians we all need to practice. So that will be my final slide, and I thank you all for your attention. I think I have a moment or two for questions, and then Dr. Landers will talk about an equally important problem, drug-resistant tuberculosis.
Thank you, Dr. Hook. Marilyn, do we have questions?
Yes. And we want to remind everybody out there, if you have a question, you can go ahead and either call in or email that question in to us. Dr. Hook, earlier you talked about the sharp increase in sexually transmitted diseases in the United States. Do you have any insights on what's fueling that increase?
What a good question, Marilyn. Thank you for that question. It's important to realize, I think we all want the easy way out. We would like to know what is the one reason that STIs have become more common? I don't think there's one reason. I think there are multiple reasons. I think very clearly one contributor is that our success in controlling one sexually transmitted infection, HIV, has made it less threatening. And because it's less threatening, unsafe sexual practices have become more common for people at risk for these diseases. So that's one thing. I think changes in our healthcare system have made it more difficult in some patients to make access to seek health care in a timely fashion. Unfortunately, it's not too uncommon in our clinic to see patients who have insurance who have called their doctor's office and have been unable to get in for a week or two. Well, that's not a good thing for somebody who has symptoms of STIs or who's been recently exposed to a sexual partner. So those are two of the numerous factors which contribute. Great question.
Thank you.
Additional questions?
Yes. You spoke earlier about the individuals at highest risk, and you were saying we need to educate those populations to reduce the incidence of gonorrhea. Do you know of any specific educational programs or initiatives that are going on that focus on this population?
Another great question. I think I have several comments about behavior change and education for our patients. I think that the clinicians listening to this talk need to realize that every one of them and every one of their patients is unique. So every message is unique. And just because your patient may have heard the messages regarding safer sex or expeditious therapy before doesn't mean that you might not connect with them in a way that other providers have not. I think condoms continue to be promoted, and sometimes the unfortunate occurrence of a sexually transmitted disease provides an opportunity, a window for behavior change as well. I think that the other issue and the other thing that we've tried to do more recently over the past decade is that as clinicians, we've moved our counseling in patients, and we're no longer in the search for disease. I think finger pointing and stigma are not helpful for people. It's not somebody's fault. We generally know that most people who transmit sexually transmitted infections, including gonorrhea, do it without knowing that they're infected. And so what we've started talking to our patients is regular testing and expeditious therapy, not because it's somebody's fault, but because we're interested in their sexual health and there are good things we can do it. And so taking a sexual health-oriented prevention framework rather than a find the disease, regret you had it kind of framework also seems to be helpful to our clients.
Awesome. Thank you. We have another question here. What do you think has caused the reduction in the pipeline of antibiotics to treat gonorrhea?
Oh, what a great question. I wish excuse me. I think the answer is that the pharmaceutical company is interested in drugs that people will take every day for their whole life and that changes their life. So people take statins, and once they start to take them, they take them for their whole life. On the other hand, antibiotics are taken for a short period of time. In terms of gonorrhea, they're only taken once. And so the profit margin, quite frankly, is not so great. And so it'll only be through partnerships, through public health agencies like NIH, CDC, and GARD-P that we spoke about earlier, that hopefully we'll have new drugs for public health.
Thank you. All right, the final question I have here says, how far off is the possibility of having a vaccine for gonorrhea?
Great question. There's great hope. There was a vaccine that was given for a related bacteria, the meningococcus, in New Zealand. And when they went back and studied it, they found that people who had received the vaccine were less likely to get gonorrhea than people who had not received the vaccine for meningococci. The vaccine that was used was sort of a specialized vaccine created only in New Zealand. So the meeting that will be held in Switzerland next month on gonococcal vaccines is designed to encourage further studies to evaluate this. But the question was how far? Don't hold your breath. I think we're talking at least 5 to 10 years before we have a gonococcal vaccine, but I think there is great hope. Thank you for those questions.
Thank you. Those are all the questions I have.
Dr. Hook, I want to tell you how much we appreciate your discussion today. It's been very informative, and we look forward to information in the future on this very important project.
It's a pleasure to be here. I hope that my comments have been helpful to those people out there.
Thank you so much.
Thank you, Dr. Landers.
And now I think we're going to proceed on with my discussion regarding multi-drug resistant tuberculosis. And what we will be talking about today will be just a brief overview of this very complex topic. But it will be information that I think the audience as nurses and other healthcare providers can use to be aware of screening patients, of having an index of suspicion, and ensuring that we are thinking about multi-drug resistant TB and extensively drug resistant TB as well as TB in general. So I did not put on this slide, but I do have no disclosures just in case anyone has any questions about this. Before we have a discussion about the specific definitions of multi-drug resistant TB and extensively drug resistant TB, I want to just put a slide up that will inspire us to think tuberculosis. So often in our clinical settings, we have patients who present with pulmonary symptoms, and of course, you know, in this era, tuberculosis, with our having less than 10,000 cases of TB overall per year in the United States, is not the first thing that people think about. But we have to remember that there are risk factors for tuberculosis that we need to consider anytime a person presents with a pulmonary lesion or a pulmonary symptomatology. First of all, we have to remember that, you know, if we have a person come in that has a persistent cough greater than a couple of weeks, we need to think tuberculosis. If we have a person who comes in who may not have been in the healthcare system recently, may not have been accessing health care, we need to think about tuberculosis. We need to think about comorbidities that put persons with TB infection at risk for disease, such as persons with diabetes, or persons with HIV, or persons who have been on immunosuppressive therapies, persons who may have been on TNF-alpha, or other agents, anything that might have put them more at risk for tuberculosis. We need to look at persons that might be from socioeconomic groups that are challenged, or situations of health disparity. We need to be aware if persons have been have entered the United States from a foreign country, have entered from a country of high risk for tuberculosis. So in other words, we need to think about TB. And in terms of the epidemiology, as I mentioned, we have about 9,000 or so cases of TB in the United States per year. I just looked at the information for Alabama. We are going to have probably 100 plus cases of TB in the state of Alabama this year, but overall that is a slight decrease from what we had last year and about what we've been trending. Again, you know, it's still TB, and it's still a disease that we have not been seeing as much over the last number of years, so people don't have as much experience handling it. Now, when we talk about the epidemiology of tuberculosis and talk about multi-drug resistant or extensively drug-resistant TB, which again I will define shortly, we have to remember that worldwide tuberculosis is still quite a threat, and that about 500,000 or so people per year in the world will have multi-drug resistant TB. And of that 500,000, about a third of these people will die from multi-drug resistant TB, and this includes adults and children. So we don't need to think, well, you know, that is in another country and that's not really something we need to think about. This is a deadly disease. This is a killer. Now, again, when we think about countries that have the highest burden for multi-drug resistant or even extensively drug resistant TB, those countries are India, China, and the former Soviet Union, the former Soviet bloc. They have a higher incidence of multi-drug resistant TB. However, that does not mean we cannot see multi-drug resistant TB from other countries and other areas of the world, including Central and South America and Africa. We also have to remember when we are looking at multi-drug resistant TB, as Dr. Hook said earlier, these organisms, again, once they start becoming in contact with antibiotics, which TB drugs are, then the organisms are very clever and they will find a way around being killed by these antibiotics. And that's why we have to be extremely careful in our regimens to give an appropriate regimen with appropriate dosing to reduce the risk of drug resistance emerging. So let's talk about what we would have in terms of a high index of suspicion for drug resistance. As I mentioned earlier, persons that might be foreign-born or might be previously treated with tuberculosis, but let's also remember patients that have poor compliance, which I have to remind everyone that compliance is probably less of a problem in our state because of our insistence on the use of directly observed therapy. Now, again, there may be ways to do directly observed therapy without actually physically meeting the patient with the newer mechanisms such as Skype or such as FaceTime, but again, still directly observing the therapy. We also have to remember in terms of factors for drug resistant, persons that might have drug-sensitive TB, but they don't respond well because of the extent of their disease, because of a comorbid condition, because of absorption of the drugs, that we actually can create drug resistance. And I think this is a big fear for those of us who work in TB control, is that we start out with, as Dr. Hook mentioned, the correct drugs and the correct dosage regimen, and that we monitor the patient very closely, because another factor we have to consider in development of drug resistance is persons who don't respond well clinically to the regimen that we have them taking. For example, persons who take longer than 3 months, that's really kind of an outside range to convert their sputum smear if they have pulmonary tuberculosis. So again, a high index of suspicion for drug resistance. But again, to kind of step back a little bit and talk about when a person comes into our ER or comes into our clinic and they have this picture. Okay, we cannot look at this picture and say, oh, that's TB. Oh, that's drug-resistant TB. We can't do that just from the picture here. What we can say here is that we have, and I had actually used this slide in another presentation, that we have a pulmonary lesion here and we have a cavity. And that's really all we can say here. Other pneumonias can cause cavitary lesions. So, but again, I would certainly look at this and immediately think tuberculosis. I mean, because that is something we don't need to miss. So what would be our approach to this patient? Well, our approach to this patient, of course, first of all, just from a practical standpoint, if I saw this x-ray, I would certainly want this patient to be in respiratory isolation, because I don't want this patient to expose other persons in the clinic or in the room. So once I had this x-ray, I need to get this person in isolation. And, you know, one thing, again, if we're in a clinic setting, we may not have a room, a negative pressure room, but we can certainly put a surgical mask on the patient. And let me say here, a surgical mask on the patient. N95 on the healthcare workers, but a surgical mask on the patient. So we're going to mask this patient. Certainly in the course of doing our history and physical, we're going to obtain other information. But let me just hone in to talk about tuberculosis here. We're going to get multiple sputums on this patient. We'll get a minimum of 3 sputums on this patient. And in the Alabama Department of Public Health, and I will be talking a little bit more about molecular testing in a moment, but we'll be getting a PCR or nucleic acid amplification test on this patient. In our health department, if we have a smear positive, if this person has a sputum that goes to the state lab and it's smear positive, they're going to get a PCR. But there are instances where we might request a PCR even if the smear is negative, because it takes a certain number of organisms to have a positive smear. So we want to make sure that if we think tuberculosis, that we try to do everything we can to rule in or rule out tuberculosis there, and it's not just a one-test situation. Certainly this person's also going to get, hopefully, an IGRA instead of a PPD, and further assessment and further evaluation and consultation and being treated as a suspect tuberculosis. And let me mention just here, of course, we as the Alabama Department of Public Health take a great deal of pride in our knowledge of tuberculosis, but also our access to experts such as the Southeastern Tuberculosis Center in Florida, as well as other centers of excellence in the United States, and we have our own experts within the state. So again, this x-ray presents to us, we're going to do a history, we're going to do a physical examination, we're going to obtain other appropriate laboratory testing on this person, an interferon gamma release assay, hopefully instead of a PPD, and we're going to do sputums ×3 for AFB, including, as many people will know, that Dr. Lander says PCR1 even if negative, which basically means that even if the smear is negative, I want to get at least one PCR. Now I want to show another x-ray, and again I've shown this is actually a child's x-ray, and both of these patients, I have seen these. Someone asked me if I had any x-rays of TB. I said, you know, I have a million of them, but this particular child, as you see, has some significant consolidation. This is an AP projection. It always makes the heart look larger, but there is a significant consolidation, and I show this to remind people that children can certainly contract tuberculosis from their parents or other caregivers, and there's nothing that says that a child cannot get multi-drug resistant TB if they have been around the appropriate persons to do that. So what are the concerns about multi-drug resistant TB, and what is multi-drug resistant TB? Well, again, multi-drug resistant TB by definition is a tuberculosis organism that is resistant to at least isoniazid and rifampin. That does not mean that the organism may not be resistant to other TB medications, but at least INH and rifampin. And again, in our experience in Alabama, we have seen patients with multi-drug resistant TB with simply these two, which simply doesn't sound like a good word, but you know, if I have INH and rifampin resistant, that still gives me an opportunity to use other regimens, as opposed to having a situation where this person is not only resistant to INH and rifampin, but PZA and, you know, EMB, and it really, you know, starts to cascade. Again, this immediately requires additional consideration for treatment, including second-line drugs. Okay, so let's talk about our concerns here. As I mentioned earlier, if we have a situation where, as I mentioned, we send a PCR to the lab, how is that going to help us? Well, I'll talk about molecular testing again in just a moment. But in our state lab here in Alabama, when we send a specimen to the state lab, and I say PCR even if negative, what I'm asking for is, again, molecular testing to determine if there's any DNA there, any TB DNA, and also our PCR testing will screen and pick up for rifampin resistance. And rifampin resistance is a marker for other drug resistance. So what basically happens there is, if I get a positive PCR back and also, well, this person appears to be rifampin resistant, certainly that's going to have to be confirmed whether or not that is resistance only to rifampin or to other drugs. I mean, there has to be more confirmatory testing, but at least I can start out and say, okay, I've got a person that is PCR positive, they've got TB. Does this also, and they're rifampin resistance, okay, then I've got a marker for drug resistance. Now, depending on how ill that person is, we may or may not try to start a regimen, but that has its own complexity. So we'll talk about that when we talk about testing for this. We don't really just jump into a regimen without further information. So again, as I mentioned, the concerns here, and we've talked about, these are the risk factors, these are the situations that we might have to occur. Again, I think I've already mentioned that. So let's talk about, before I go into molecular drug testing, what extensively drug-resistant TB is. Now, I mentioned multi-drug resistant, that's isoniazid and rifampin resistance at a minimum. Now, there's kind of an in-between here, a pre-extensively drug-resistant and an extensively drug-resistant. But multi-drug resistant TB plus resistance to a fluoroquinolone drug and at least one of the 3 injectables, amikacin, kanamycin, capreomycin. Any of these just further complicates our ability to treat the patients. Now, as I mentioned, there's kind of an in-between where we call it a pre-XDR. A pre-XDR is a multi-drug resistant patient with either a resistance to fluoroquinolone or an injectable, but not both. So that is a pre-XDR. And again, these are situations that are very, very, very challenging to treat. Now, because I've talked about the challenges here, one might say, okay, well, how much of this do we have in Alabama? Well, certainly as we talk about what we have worldwide, it's a very significant problem. In Alabama, we will probably have a case or two of multi-drug resistant tuberculosis in our state that we're treating at any given time. We may have, and we have had, some pre-XDR cases, which, as I mentioned, that's resistant to at least INH and rifampin, and then, of course, resistance to either a fluoroquinolone or an injectable, a pre-XDR. And again, these are challenging cases to treat. We have not had an XDR patient in the state of Alabama, although I have been aware of XDR cases. What we have to remember here is with any drug resistance, even if we just have a resistance to INH or rifampin, and I say just have, I mean those are still significant, but what we have to remember is if we have a monoresistance to INH or a monoresistance to rifampin, we're one resistance away from a multi-drug resistance. So it's incumbent upon us to get the right regimen for these patients. And as I mentioned earlier, we talk about extensively drug resistant. It is so much harder to treat these patients, and we'll talk about treatment a little bit in a moment. I think the key concerns that we have to look at is that, first of all, we have to try to prevent acquired resistance by using an appropriate regimen starting out, appropriate doses with appropriate drug levels. And drug levels have become more of a standard for us in patients who have comorbidities such as diabetes, where they may have less absorption of the medication, other situations that we may have challenges with. So I think prevention of acquired resistance by an appropriate regimen initially, and then also monitoring the patients with DOT, adjusting the doses of the medication to ensure that we don't develop emerging resistance, excuse me, as well as prevention of transmission of MDR or pre-XDR or XDR to contacts. And this is why a very robust contact investigation must be carried out anytime we have a tuberculosis case, but it becomes much more of an issue when we have a suspicion of drug resistance or pre-XDR, because we do not have good preventive regimens for MDR, pre-XDR, or XDR. When we're trying to come up with a preventive regimen of patients who have been exposed to these resistance patterns, it's really a challenge. And while we look at literature, we know that there's not a lot out there. There are not a lot of studies that show that this is, that this is really a good preventive regimen. And again, certainly on our third bullet point, if we have contacts that have been infected with presumed MDR, pre-XDR, or XDR, then we consult with experts to determine what regimen of prevention might be appropriate. Now, let's talk about diagnosis here. And when I talk about diagnosis, again, as I've said, we've already talked about a history, a physical, the epidemiologic factors there. We want to talk about we have our radiographic findings, or if we have TB at another site, primarily focusing here on pulmonary, but certainly we can have TB at other sites in the body. What are the diagnostic diagnostic tools that we have that can help us when we're looking for multi-drug resistant pre-XDR or extensively drug resistance? Well, I really think that doing the nucleic acid amplification test, the PCR testing, has been revolutionary for us in Alabama, because if you have patients that, for example, we do sputum specimens on them and they're PCR positive and can take that to the bank, that's probably TB. Now, that does not mean that we're not going to do cultures. It just means that those tests are highly sensitive, highly specific, and we can go ahead and start a regimen on a presumed drug sensitive case. The challenge is when the lab calls us up and says, okay, well, we think we have rifampin resistance here. Again, in our laboratory, we can do nucleic acid amplification testing, or PCR, on respiratory specimens. However, other specimens that need to be tested that we might have, for example, in a child, if we have gastric aspirates, if we have a CSF, if we have tissue, if we have pleural fluid, these are we cannot test that in our laboratory for PCR, but we can send that tissue or that fluid to reference laboratories through our mechanisms through the Florida Department of Public Health or the CDC. So again, let's step back and say, well, what do I do when I have a suspected MDR or a suspected pre-XDR? And really all I'm saying here is, okay, the lab calls, they give us this appears to be a rifampin resistance. Again, we're really checking here. We're not sequencing here, but we take that sputum or respiratory fluid, and we send that on to a reference laboratory. Now, the CDC, of course, we can do the molecular detection for drug resistance, and that's sequencing, looking for resistance patterns, and that takes probably a couple of days or so once the specimen gets over to the CDC. We also work with the Florida Department of Public Health with the HON test, which can do some sequencing and give us an idea of not only whether or not we've got rifampin resistance, but again, both with the MDDR and the HON, do we have resistance to other organisms? And again, just looking at these molecular tests, I think this has revolutionized what we're doing in TB, because it has given us an opportunity to tailor a regimen for the patient until we can get the final cultures. Now, the cultures are still the gold standard, but again, this molecular testing allows us to basically come up with a regimen that is appropriate for this patient until we have our final cultures. Now, the challenges with molecular testing, and let me say that this is still something that we're learning about. This is still something that is relatively new, and also the language of interpretation of molecular testing. I like to say, don't try to do this at home, okay? Basically, when you have a situation this complex, we must consult with multiple experts. And again, reading the results of the MDDR and the HON, just for example, and I do this, and I myself like to get other eyes on this and say, okay, well, this is what I'm seeing, this is what this looks like, this is what I'm thinking. I'll ask other experts, do you agree, and what do you think here, and how can we build a regimen based upon the molecular testing that we have. Now, there may be instances where, and again, when we suspect an MDR or pre-XDR, we're going to get this additional testing before we start the regimen. Occasionally, there may be instances where we actually are waiting for culture information on some patients, again, depending on how ill the patient is, you know, whether or not you feel that you can wait versus do you need to go ahead and build an empiric regimen based upon your MDDR, based upon your HON. Again, this is not perfect, but it's certainly a vast improvement over what we have had in the past. And additionally, I think what this allows us to do is to get that person on a regimen and get started on their treatment and basically reduce their chance of transmission to other people. And that is obviously something that we really need to be aware of. So what is the treatment? Now, I deliberately did not list all of the drugs here because this is, again, this is not something for you to try at home. If you think that you have a multi-drug resistant TB based upon our PCR information, we send further testing to Florida and or CDC, and sometimes we'll send to National Jewish, we'll send to other places. If we feel that we're dealing with this, first thing we're going to do, we're going to consult with an expert, with multiple experts. The cases that we've had here in Alabama, it is not uncommon for us to be on the phone with the SNTC, with at least 2 of their experts, and with one of our clinicians, and also another clinician that we have here in the state of Alabama who assist us. So it's not unusual to have multiple experts. The general principles of the treatment of multi-drug resistant TB or pre-extensively drug resistant or extensively drug resistant TB are, first of all, to recognize the complexity. Be aware that this regimen is going to have to be tailored based upon what we know from our molecular testing. We have to build a regimen. And at the end of this discussion, there will be a reference from Curry International, and it's called the Survival Guide for Drug-Resistant TB. And trust me, it is a survival guide because we really have to have this. And it really gives a template, if you will, to building a regimen. Basically, the drugs you select, then drugs you add on in terms of treatment. Also at Curry, there is a 3-part video series by Dr. Penn Berry and Dr. Lisa Chen, and I believe one other expert, that speaks to the principles of drug-resistant TB and also how to build a regimen for these patients. Another thing we have to remember is that when we are treating drug-resistant TB, we will be using multiple drugs. Now again, with drug-sensitive TB, we're using 4 drugs, so that's multiple drugs. With drug-resistant TB, we are using multiple drugs. So again, to recognize, really for the most part in the drug-resistant cases that I have been involved in my career, we're usually using at least 6 drugs. Sometimes we're using 7. But again, the more you're using, the more likely that you're going to have side effects, and clearly you're going to have to do therapeutic drug monitoring. I mean, that is just an absolute. And again, all of this is directly observed therapy. There is no self-administration in such instances. So you're going to have a large regimen with 6+ drugs. You're going to have to do therapeutic drug monitoring of the drug levels. You're going to have to be very aware that when you move out of our standard drug therapy of isoniazid, rifampin, PZA, and EMB for our drug-sensitive cases, you move out of that, you're going to increase your side effects. You're going to have to expect side effects, as well as having to do, again, some standard monitoring. For example, some of our drugs that we use in multi-drug resistant TB require testing such as regular EKGs. So again, this is something to be aware of. Additionally, when we are treating a patient for multi-drug resistant TB, the regimen is long. And people sometimes say, well, how long is the regimen going to be? Very long. While there is some research in other parts of the world on shortening the regimens for multi-drug resistant TB, we have to be aware that for the cases that we have treated here in Alabama, I mean, 18 to 24 months is what we've seen. Again, treating the patient for a minimum in the induction phase, a minimum of 6 months after conversion, if it's pulmonary, after conversion of their sputum, and then up to 12 to 18 months of the continuation phase. So we're really talking 18 to 24 months of therapy, a very long regimen. And then with drug-resistant tuberculosis, as with any condition, certainly we want to monitor the patient's progress once they complete therapy. But with drug-resistant tuberculosis, we're going to be monitoring these patients for a minimum of 2 years after they complete their regimen, with regular, every 3-month clinical assessment, history, find out what's going on in terms of any symptoms they might have. Additionally, regular sputum specimens, we're doing those about every 3 months or so. Now with radiology, again, because some of these patients, even after they complete their regimen, their x-ray is still going to have some abnormalities, and the x-rays will change and hopefully continue to improve, but x-rays on a periodic basis, so a minimum of a couple of years of follow-up. And in talking about the drugs that we're using with with multi-drug resistant TB and extensively drug-resistant TB, once we move out of the standard drug-sensitive regimens, not only does the complexity go up, but the cost goes up. So there, again, is a significant amount of work that goes into managing these patients. Fortunately, we don't have a large number of multi-drug resistant TB cases in Alabama, but again, those that we have, it's almost a full-time job for just 1 or 2 patients. I'm going to mention in just the last couple of minutes that I have here, because I do want to move on to the opportunity for questions. I just want to say that really in the last few years, we've had a case of multi-drug resistant TB from Vietnam, and we know that people travel back and forth, so I remind people that when you're traveling to other countries and you're there for a period of time, you might be working in that population, there is certainly a concern of contracting tuberculosis, and we have had a case from Vietnam. We've also had a case from Nigeria, which had quite an extensive drug resistance pattern. And also, we had a case from China that we thought was a multi-drug resistant. And as I mentioned, China is a country that has more multi-drug resistance than some other parts of the world. What we did find out is the person from China turned out to be a rifampin resistant only, which is really overall pretty uncommon, although I do understand from some discussions with Curry that on the West Coast they have a higher incidence of rifampin only resistance in patients coming from China. However, what we have to remember is we are one resistance away from a multi-drug resistance when we have, for example, a rifampin resistance. So it's incumbent upon us to give an appropriate regimen with an adequate number of drugs being monitored over a longer period of time with directly observed therapy in order to reduce the risk of not only creating additional resistance, but also having persons that have a not as good a chance of recovering and finally transmitting this to other people. We're going to take a brief break here and come back to answer questions, and then Marilyn will do the final wrap-up. And I'm going to just have these websites on my resources. All of these are great websites, and I would urge you to look at those for much more extensive information than this brief overview. So, Marilyn, we'll take a 5-minute break. Welcome back to our discussion today on superbugs. Again, we've talked about gonorrhea and we've talked about tuberculosis. And Marilyn has a couple of questions before we wrap up with Infection Control 2018. Marilyn?
Thank you, Dr. Landers. Just a couple of questions on the subject of multi-drug resistant TB and extensively resistant TB. In our society, we've heard a lot about multi-drug resistant TB. When did the concept of extensively resistant TB arise?
Okay. Well, actually, with multi-drug resistant TB, you know, we've certainly seen that over a number of years, especially as we have had challenges with getting patients appropriately treated in terms of adherence to therapy, in terms of following directly observed therapy. And so some of our multi-drug resistant has regrettably come from an inappropriate or inadequate regimen. Also, we do know that from countries that have a high burden of multi-drug resistant TB, that again the same situation, access to medications or intermittent administration of medication has led to their drug resistant, their multiply drug resistant cases. Now more recently, and again I don't remember the exact year that this happened, but more recently there have been cases of extensively drug resistant TB in other parts of the world, and a few cases that have come to the United States for treatment. But as far as I think the challenge we're dealing with right now is that we need to reduce the risk of drug emergence or drug resistance emergence by appropriate treatment regimens of drug-sensitive TB, and that includes what we've talked about earlier, and that is, first of all, an appropriate regimen with appropriate dosage and appropriate monitoring on drug-sensitive so that we don't have drug resistance to emerge. But if we have a suspected multi-drug resistant TB, that we do appropriate testing, as I mentioned, molecular testing and following up with cultures and getting those patients on an appropriately built regimen starting out. Certainly we would not want to treat a suspected multi-drug resistant TB or a pre-XDR or an XDR with a standard regimen until we got cultures back, because if we're just putting those antibiotics in the body, again, those organisms are going to rapidly develop resistance. So again, we've seen ourselves go, especially with the challenges in the healthcare system in third world countries, from drug sensitive to more and more drug resistance, so that now again, as I mentioned, countries that have more risk for that. But again, we can certainly have multi-drug resistance in our own country from persons that acquired TB here if we don't have an appropriate regimen for them. So I think the challenge is to be on the lookout and be aware. Patients previously treated, patients from high-risk countries, patients with other comorbid health conditions, we need to be on the lookout for this and do appropriate testing.
So there is no standard TB case?
Not really. I asked one of my colleagues not too long ago, where is the regular TB? Because we do, even with our drug-sensitive cases, we have patients with other medications that might interact with the standard regimen, or we might have patients with comorbidities. So again, the tuberculosis we have now is becoming more challenging to manage, whether it is drug-sensitive or a multi-drug resistant, or even a mono-resistant.
Thank you.
So.
Well, and my final question, earlier you mentioned that MDR and XDR patients can be followed anywhere from 18 to 24 months after completing their regimen. Have you found any instances or cases where there's been a failure or a transmission of MDR, XDR, even after that long, lengthy time to follow up those types of patients?
Well, fortunately, in my experience with the MDR and pre-XDR, I've not seen an XDR other than in a setting where a person was being treated, and I happen to be aware of that in another state. But fortunately, in the experience that I have had, the patients that we have treated and we have followed thus far have done well, which is good, because we do know that, again, based upon the resistance pattern and the difficulty of treating the regimen, the more resistance there is, the more difficult the regimen is, the more likelihood that the person may relapse down the road. So that's why a minimum of 2 years of follow-up. Fortunately, in the cases that I have personally been involved in, and the cases that we're monitoring now, patients are doing satisfactorily, and for that we're very grateful. But even after that 2-year monitoring period, there certainly can be relapse down the road. I have had a monoresistant case, a person who was resistant just to INH that actually relapsed after 5 years. Wow. So that happened within the last year here. So again, it's incumbent upon us that once we treat a patient for tuberculosis, whether it's drug resistant or drug sensitive, which obviously we treat much more drug sensitive in Alabama, that we educate the patient, provide them information, and remind them that, you know, in the future, if they have any signs or symptoms related to tuberculosis, or if they have a change in their health status, such as being on immunosuppressive therapy or something of that nature, that get back in touch with us. Overall, the way we're going to reduce tuberculosis transmission and control tuberculosis is really how we've gotten to the small number of TB cases today, and that is through good public health and through good contact investigation and through preventive measures and through directly observed therapy.
Thank you, Dr. Landers.
Thank you.
Very valuable information.
Thank you.
All right, so we're going to move into the final presentation of our program on today. We do hope that you will take this information that's been provided by Dr. Hook and Dr. Landers back into your public health nursing practice, because it's good information and it does affect our Alabama public health patient population. So we wrap up this portion of the presentation with a review and a restatement of our infection control. We want to remind you of the CDC guidelines for infection prevention in outpatient settings. Always, hand hygiene, using your PPE, injection safety, environmental cleaning, medical equipment cleaning, and respiratory hygiene or cough etiquette are very important to us as we administer services to public health patients. I want to remind you that hand hygiene is the preferred method for hand hygiene, and the use of alcohol-based hand rub, except when hands are visibly soiled. If hands are soiled with dirt, blood, body fluids, or other substances, washing with soap and water is more effective. Hand washing is still one of the top methods for reducing the transmission of infection. I know oftentimes we're in a hurry, oftentimes we're trying to get the patient seen, but we cannot afford to skip on the time that it takes to do hand hygiene. Everybody knows the little sing the birthday song while you're washing hands, but sometimes we get in such a rush, we don't take the time to do that. So we always want to remind everybody, proper hand hygiene is very important to reduce the spread of diseases. Remember, you always want to wash your hands before and after physical contact with your patient. You want to wash hands if you have any type of contact with blood, body fluids, or items that contain blood, body fluids, or other secretions from the patient, always before performing aseptic tasks and after gloves have been removed. Remember, your PPE is very important to you. PPE protects you. It needs to be used at all times when appropriate to prevent contact with infectious substances. It should always be donned when there is a potential of exposure to blood, body fluids, or other infectious substances. Things to remember when you're using your PPE: remove and discard all PPE before leaving the patient care area. Perform hand hygiene immediately following the removal of gloves, and PPE should always be changed between patients. When it comes to injection safety, remember, for ambulatory care settings, injection practices can lead to the patient or healthcare provider injury. You always want to use, in our health departments, we always use retractable injection and venipuncture supplies, which greatly reduce the risk of there being a injection injury. Always employ aseptic techniques when preparing and administering medications. Never reuse a syringe. Always use retractable devices according to the manufacturer's instructions, and all injection devices need to be discarded in an approved sharps container. For environmental cleaning and disinfection of surfaces in the patient care area should be conducted on a regular basis. I know we talked about this in years past. Sometimes we get busy seeing patients and we forget that equipment needs to be cleaned. Blood pressure cuffs, items that are used on multiple patients should have a regular schedule for being cleaned, and anytime there's any type of visible soil or contamination, they need to be scrubbed and a disinfectant and water used to clean those substances. Disinfecting should involve the use of an approved microbial inactivation substance that eliminates recognized pathogenic microorganisms. You need a regular schedule. Use only EPA-approved disinfectant and always follow the manufacturer instructions for the use of these disinfectants. When it comes to medical equipment, a plan and procedure for cleaning of reusable medical equipment should be established to prevent the transmission of infectious diseases. Critical items such as surgical instruments should be sterilized according to the manufacturer's instruction. Non-critical items such as blood pressure cuffs and other reusable points of care should be cleaned regularly. When it comes to respiratory hygiene and cough etiquette, we're in the heart of the flu season. We want to remind you this is very important to the safety of not only patients, but also to our employees. Respiratory and cough etiquette techniques should be utilized with patients and other visitors to the health care facility to prevent transmission of respiratory infections. Cover your cough signage should be posted in areas visible to the patients and visitors. If that signage is needed, I'm sure you can contact the appropriate division here at the central office and they can get that signage for you. But we always need cough signage in patient care areas. Respiratory care items such as tissue and masks should be made available for individuals with signs and symptoms of respiratory illness, and immediately perform hand hygiene should hands come in contact with respiratory secretions. Here is the guide for infection prevention for outpatient setting. If you have additional if you need additional information, this guide will provide ample instructions and information for outpatient settings. Thank you.
Marilyn, this has been a very informative discussion today. Certainly Dr. Hook's presentation was a wonderful introduction to what we need to be thinking about in terms of GC. I hope that the information I've provided to the nurses about MDR and pre-XDR and XDR allows them to think about that subject and think about TB in a broader context, as well as finally implementing these infection control standards in order to protect our patients and our employees. This concludes our program for today. I want to thank Dr. Hook and Marilyn for joining me, and thank you for watching. Have a great day.